Do the ovaries still make a physiologic amount of testosterone that's of value after menopause? I mean, I know that there was this whole push, I think, like when we were in training, I'm a little bit older than you, but it was, if you get a hysterectomy, leave the ovaries out. And the last 10 or 15 years or so have been like, leave them in no matter what, unless there's something wrong with them. And now there's kind of the pendulum has swung back saying like, probably can take them out at 50, or if you take them out earlier, you can probably just give them HRT and they're fine. Like, what do we know about postmenopausal ovaries, what they do, whether it's estrogen, progesterone, testosterone, like, and how are you counseling patients on that?
Yeah, so generally the first thing that drops off is the progesterone, and that's typically because you're not really ovulating regularly anymore. So if you're not having that sort of ovulation trigger, you're not getting that same like rise in progesterone that you usually get after ovulation. So that tends to drop off first. And I think that's why I have so many patients that come in to see me who are just on progesterone because they've gotten some labs that show that they're low. And I don't see much value in that. I mean, progesterone, there's some evidence that it can help with sleep for people with sleep apnea, but in general, like nobody should just be on progesterone. Then, of course, the estrogen starts to drop off as the ovaries aren't responding more to the FSH. Even though FSH is going up and up, the ovaries are going to stop responding at some point. So the estrogen is going to drop off as well. And then testosterone's like a little bit of a lag. It's like a couple of years behind the estrogen and progesterone in terms of the drop off, because it's not really that same cyclic stimulation that we see in the ovaries for the menstrual cycle. So the ovaries are still producing some testosterone even when the estrogen and progesterone are dropping. And then, of course, we have steroid hormone production in the adrenal glands, although much less so than we were getting from the ovaries. So it is a little bit of a slow drop. Like I said, the majority of symptoms that we're seeing in perimenopause and menopause are due to, first of all, the erratic fluctuations of estrogen that are happening in perimenopause. And I will have some of those patients that come to me that are monitoring their labs all the time. I have a nurse who I see and she's always like, but the estrogen was so high. And then we kind of go through the pattern. We're like, yes, it went high because the FSH was so high and then it stimulated the estrogen. We're not going to treat the numbers. We're going to treat how people feel, kind of stabilize things along the way, and then see what we need to add back in to get you feeling better.